Thank you very much, Heather. Thank you, Roxana. So it's a true pleasure to be here with you and to present in the next during the next 15 minutes how to plan for transcatheter tricuspid valve interventions and what are the results of the main trials that Saibal had just mentioned in the previous talk. So let's start with the planning and the role of imaging. So I wanted to start with some key messages about planning for transcatheter tricuspid interventions. The first one is that planning is crucial. It is a case for the other valves. It's of paramount importance for the tricuspid valve. So it goes through proper quantification of the tricuspid regurgitation, trying to understand what is the anatomy of the patient that we're going to treat and the mechanisms of the tricuspid regurgitation. And multimodal assessment really plays a role, and it's a key to integrate all the imaging methodologies to understand the anatomy of the patients and the way we're going to use the devices in that particular patient. So you've seen with the previous talk that in functional tricuspid regurgitation, most of the time we have an enlargement of the annulus in the anterior and posterior region. And you clearly see on the left picture, the anatomical picture, that the tricuspid annulus is clearly a complex structure. The tricuspid valve is a complex structure with many surrounding structures, and we need to analyze that before going into the procedure. So echo remains central in that assessment. Echo is the gold standard because it's extremely helpful to understand what is the mechanism of the tricuspid regurgitation, to quantify that tricuspid regurgitation and localize the position of multiple jets, because it's sometimes the case. And it's also extremely important to understand what are the right ventricular volumes and function and the pulmonary arterial pressures. Saibal said that of paramount importance is to identify the presence of pacemaker leads and their location, because they may be at the origin of massive tricuspid regurgitation. So it's really difficult, it's complex to quantify tricuspid regurgitation because it's not a circular valve. And so maybe this 2D assessment that we use to apply for the other valves is not enough for the tricuspid. And we, apart from the 5-scale grading that is more and more adopted and seems to be correlated with the outcomes for the patient, there is a role for the 3D integration of the both the Doppler and the color imaging with the PISA. And the 3D EROA, 3D PISA, is something that should be integrated in the daily practice when it comes to the tricuspid valve to better quantify, to properly quantify tricuspid regurgitation. So another modality when it comes to planning and understanding the tricuspid function and regurgitation is CMR, and CMR may be implemented just to understand what is the amount of regurgitation and what is the what are the RV volumes and the RV function. So this is a more modern and contemporary way to assess the TR and the tricuspid apparatus, and this could be one of the key players in the future. To my opinion, one of the key methods for planning a procedure remains CT scan. CT scan is one of the gold standard technique on the aortic and the mitral side. It is also the case for the tricuspid side because it helps us sizing all the dimensions of the tricuspid annulus. It's even interesting because it helps us understanding where are the differing in relation to the various septal to the various leaflets of the tricuspid valve. So it's something that we need to maybe not master at the start of our experience, but to implement in terms of understanding the anatomy, the angles, the way the catheters are going to behave within the anatomy of the patient, and this is crucial before diving into the procedure. So as an example, something that we may also assess with CT scan is the location of the right coronary artery. This is a device that is not anymore utilized, studied, because it's not manufactured anymore. This was a tri-cinch coil system, and it was necessary, as it is the case also for the cardioband and the tricuspid side, to understand what is the relationship between the right coronary artery and the tricuspid annulus, because there is a risk to impinge that artery with the anchors So the overall integration of the tricuspid valve and the surrounding structures. So during the procedure, you're going to see that more and more often. It's another multimodal assessment, multimodal imaging to guide the procedure, to guide the deployment of the devices that we're going to use. So we need to integrate that to understand that we need to combine, as for it is the case, for example, for the TriClip, the echo imaging and the fluoro imaging, and this is meant to really guide us towards the location of the jets and to navigate through the various structures before reaching the tricuspid valve. So if to make it quite more synthetic in terms of planning, if we do a kind of overview of the imaging modalities for planning and procedural guiding, if we start with the echo for pre-procedural planning, it's all about TR mechanism and severity assessment of the right ventricular function and volumes, estimation of both the right atrial and the pulmonary arterial pressures also. While when you go more into the procedure, the guiding through the procedure, it's really helpful to visualize the catheters and the leads, to identify the location of the jets and the target points, and to assess the immediate results. We may also use the fusion imaging when it comes to echo guidance. For CT scan, it's all about the measurements, the true measurements of the dimensions of the tricuspid annulus and the RV dimensions, but also the subvalvular apparatus may be assessed, as can be the surrounding structures, whether it be the coronary sinus, the super or inferior vena cava, the right coronary arteries, so multiple ways to assess the overall anatomy of the patient. For the procedure, it's a superb tool to anticipate the angles and the optimal projections for the fluoro C-arm. Fluoroscopy, to my opinion, it's mainly for the opacification of the right coronary artery and to guide the navigation of the catheters through the inferior vena cava, superior vena cava to the right atrium, and then the right ventricle across the tricuspid annulus. So this is definitely a multimodal integration of these imaging modalities to plan your procedure. So we've seen what were the available options for the tricuspid regurgitation in terms of transcatheter techniques. I will start by just showing this slide that clearly tells us that we have a very large portfolio of available devices for various targeting various aspects of the tricuspid valve, whether it be direct suture annuloplasty, direct ring annuloplasty, coaptation enhancement devices, or TTVR, transcatheter tricuspid valve replacement technique. So a very large portfolio of devices under clinical evaluation, and this is really superb for our patients. So the TriClip, the clipping of the tricuspid valve is the most popular one so far, and we has gathered most of the experience in the tricuspid side, with more than 2,000 procedures performed worldwide, which is already a good number. And you've seen the triluminate study, but before that there were real-world registries, and from these real-world registries, what we understood is that if we achieve procedural success when it comes to clipping the tricuspid valve, this is going to have a positive impact on the survival of the patients. The patients for a procedural success have a better survival as compared to the patients with a procedural failure. So if we go for the procedure, we should do our best to decrease the tricuspid regurgitation, because this is going to have an impact for our patients. The TriClip has been described in the previous talk, and this is definitely a device that is designed for the tricuspid. And we just focus on the triluminate trial, 85 patients that was meant to evaluate the safety and performance of the TriClip in symptomatic patients with moderate or greater tricuspid regurgitation. And definitely, you're going to see that first, in terms of procedural success, this was extremely impressive with 100% procedural success rates. And this is clearly, clearly illustrates the safety of the procedure in the tricuspid side. We had seen that in the mitral side. It's even greater and even safer. It seems to be safer in terms of procedural aspects on the tricuspid side, and this is really reassuring for the patients. When we focus on the primary safety endpoint at 6 months, you can see that 94% of the patients were free of any major adverse cardiovascular events, namely cardiovascular mortality, myocardial infarction, stroke, new onset renal failure. And this the pattern was sustained at 1 year, with 93% of the patients being free of major adverse events. Once again, extremely positive signals for this therapy. So the goal, the ultimate goal, the first goal was to achieve a TR reduction. And what you can see on the left part of the slide is that the TR moved from massive to torrential in more than 65% of the patients at baseline, to only 27% at 1 year having severe or torrential regurgitation. So it's clearly an improvement for the patient. And this TR reduction seems to be sustained at 1 year. Some patients had a worsening of their regurgitation, but the vast majority of the patients kept the degree of reduction of the TR that was achieved after a procedure. As a consequence, improvement in quality of life, improvement in symptoms with a lower NYHA scale, both at 30 days and 1 year. And they also observed early signals of right ventricular positive remodeling. And this is something that is strongly encouraging. It needs further exploration, but these are very great early signals. In terms of hospitalization, if you live a regurgitation that is more than moderate, the patients are going to face a greater risk of rehospitalization. So once again, we need to achieve the better outcomes in the OR or in the cath lab when we use the TriClip technology. The competitor or the device that has the same mode of action as the TriClip is the Pascal. We all know the Pascal device, and through the compassionate use experience with the 28 patients that were treated, extremely impressive in terms of TR reduction, comparable to the TriClip, with very few patients having a severe or torrential regurgitation at 30 days. And this is correlated to an improvement, symptomatic improvement of the patients, and also in terms of quality of life. So once again, very positive early signals that need to be confirmed through larger cohorts and longer term follow-ups. When we move to the cardioband and more the annuloplasty devices, annuloplasty systems, the cardioband is, we have to be honest, is more challenging to utilize in the tricuspid valve. And this may correlate, as you can see, to greater amount of severe, massive or torrential regurgitation as compared to what was achieved with both the TriClip and the Pascal device in the tricuspid side. It's a little bit more complex with the cardioband, but the patients who had a significant reduction of the TR had a symptomatic symptoms improvement and quality of life improvement also. So if we understand how to use the device, how to better select the patient that are going to benefit from that technology, there may be a future for the cardioband in the tricuspid side. A device that may challenge the cardioband is the Da Vinci system, and the first in-man case was published very recently. It's a two-step procedure. The ring is placed during an index procedure through the jugular axis, and then the cinching is performed only 90 days after, just to have a proper sealing and anchoring endothelialization of the anchors all around the tricuspid annulus. So this is a device that we need to follow, and we're going to see in the future what are the outcomes. The first cases are being performed, and we're going to see in the upcoming months what is the outcome for the patients. But potentially, we may not expect the results as good as the ones that we saw before for all the patients, and there may be a need for a replacement solution. This solution has been discussed previous talk. But briefly, if we take the Navigate device, the early experience on the first 30 patients treated with these devices has been published, and you can see that it's quite efficient, as are all the replacement techniques in terms of reduction of the regurgitation. So it works, and what we need is to have a longer-term follow-up. There is a need for some technical refinements because the device remains quite bulky at the present time. But in the future, there may be, if we have some appropriate technical improvements, we may face better outcomes for the patients, particularly procedural wise. Evoke is probably one of the most promising device. It has been nicely described by Sabel before. You can see that it comes from the transfemoral access with the steerable catheters in various directions. And through this compassionate use with the 25 first patient, technical success was high. 92% of the patient had a device successfully deployed in the anatomy. Only one unsuccessful procedure due to the lack of coaxiality, and one device that was deployed a little bit low and required a sapien-free implantation to prevent a residual significant regurgitation. So no mortality. So the safety profile is really impressive, really encouraging. And the ability to decrease TR is really in accordance to what we see with these replacement devices. So very few patients had a severe regurgitation post the procedure. And as a consequence, a clear improvement in terms of symptoms for the patients. So we're going to see, we know the Intrepid in the mitral side. We're going to see how it behaves in the tricuspid side. The EFS is about to start, and with this transfemoral tricuspid technique, we're going to see what are the outcomes for the patients. Promising result on the mitral side, and we can expect the same thing and potentially the same type of result as we obtained with the Evoke with the Intrepid in the tricuspid side. So to conclude and to remain in time, I would say very simply that imaging plays a central role for planning transcatheter tricuspid intervention, and we saw that it's more a multimodal assessment of all the metrics of the tricuspid valve before selecting the appropriate device. It's also a multimodal imaging guiding during the procedure. It's not, most of the time, it's not one imaging technique that is going to help us properly place the device. We need to combine most of the time 2 imaging techniques. We have a large portfolio of devices, transcatheter tricuspid devices, that are under evaluation or under commercial use, but we need to accumulate to better understand what is the patient selection to tailor the device to the patient, because every single patient is different. And we need to accumulate experience as a group, all gather our cases to better understand who to propose which technology, and we need a longer term follow-up. So I thank you very much for your attention.